If you had ever felt shoulder pain or restrictedness, seemingly out of nowhere or from previous shoulder trauma, you may have had adhesive capsulitis syndrome. Being a relatively common condition, this syndrome can cause difficulty with daily activities and diminished quality of life. More commonly known as frozen shoulder, it is a pathological condition generally attributed to inflammation. It is the product of excessive fibrosis causing obstruction and adhesions around the shoulder joint capsule. This will result in dull or aching pain, a restricted, stiff feeling, and limitations with both active and passive movement at the shoulder. So how common is it? Before talking about prevalence, it is also important to mention risk factors. The main risk factors is sex, with approximately 70% of the affected population being female, age over 40 with 84.4% of the affected population being between 40 and 59. Previous shoulder trauma, such as surgery or injuries, and extensive periods where the shoulder has been immobilized. Some conditions such as diabetes and thyroid, cerebrovascular, and autoimmune diseases are also known to contribute to the disorder's development. In the general population, approximately 2 to 5% are affected. Analyzing prevalence rates with the associated diseases, percentages increase drastically to as high as 50%. Referring to etiology, adhesive capsulitis is categorized into two types, primary and secondary. Primary is idiopathic, with development of the disability closely associated with the risk factors present in the patient. Secondary adhesive capsulitis is due to previous shoulder trauma, whether that be surgery and/or injuries. Development is also associated with prolonged periods of shoulder immobilization. With knowing the causation, how does the syndrome develop and cause disability? Although some aspects are still unclear, the clinical manifestations of adhesive capsulitis are caused by interactions of inflammation and fibrosis. An abnormal inflammation response from external stimuli or otherwise will result in reactive fibrosis. If the inflammation response lasts for longer than expected, fibrosis will cause formation of adhesions and abnormal thickening of the shoulder joint capsule, leading to the characteristic pain and decreased range of motion symptoms. The disability follows 3 developmental stages: painful, stiff, and thorny. With each stage, patients experience an increase or decrease in pain and/or stiffness. Each stage varies in duration, with the trigger for a stage to stop or start still unknown. The condition lasts on average for 1 to 3 years, but some patients may face recurring symptoms past 5. Diagnostic criterion is based on type, with both often being a diagnosis of exclusion. Both types are based off of the signs and symptoms present in the patient's history and physical examination. Primary adhesive capsulitis is more dependent on the risk factors present in the patient and if the condition occurs spontaneously. Secondary adhesive capsulitis emphasizes patient's previous physical history. So how is the syndrome normally treated? Treatment is often targeted towards systematic relief, whether that be pain management or improving shoulder range of motion in all planes. There are several non-operative treatment approaches available, ranging from pharmacological, such as NSAIDs and corticosteroids, and non-pharmacological, such as physical therapy. Operative treatment options is surgical, such as manipulation under anesthesia, and arthroscopic and open capsulotomy. All non-operative approaches aid in relieving the symptoms, allowing for easier and faster recovery. Operative approaches involve direct mobilization or manipulation of the joint capsule and usually result in faster resolution compared to non-operative methods. Aggravations to adhesive capsulitis occur with physical movement. Movements such as lifting objects overhead, directly out to the side or to the front, or row-type movements. Additionally, it is advised to avoid sporadic, rapid changes in speed and direction when utilizing the shoulder and avoid sleeping positions that place pressure onto the affected shoulder. With this being said, light and controlled movements using the shoulder is recommended and will aid in recovery and minimizing loss of range of motion. Lifestyle and self-help treatment will be focused on prevention and controlling known risk factors. Patients who maintain a healthy diet and active lifestyle, refrain from smoking, and control alcohol intake are less likely to develop known risk factors associated with adhesive capsulitis and other detrimental conditions. Chiropractic treatment targeting the cervical and thoracic spine, trigger point therapy, and soft tissue mobilization have all shown to improve or resolve adhesive capsulitis within a much shorter time frame than expected. The chiropractic approaches were also noted to reduce pain, improve mobility, break up adhesions, and improve blood flow. In my opinion, the associated diseases mentioned previously, especially in combination with other genetic or environmental risk factors, can have numerous effects on bone structure, development, and integrity that can result in spinal misalignment. In the case of adhesive capsulitis, cervical or thoracic misalignment can result in clavicle and scapular displacement. This can create an unstable anatomical and biomechanical situation in the shoulder, stretching ligaments and vascular structures. If left untreated, with the shoulder being used like normal, the result can be trauma inciting inflammatory diseases. As chiropractors treat the cervical and thoracic spine, the clavicle and scapula will realign and return to its most stable and safe position, eventually resulting in the condition being resolved. It is clear that many aspects of this condition still remain unclear or uncertain. With the results from chiropractic treatments, it is plausible that at least a cause of adhesive capsulitis is correlated to anatomical and biomechanical issues. Further case studies and investigation of the relation of spine alignment and its effects may provide further clarification on the pathophysiology of adhesive capsulitis and other syndromes. Lastly, this is the reference list of all the sources cited and referred to during the presentation. Thank you for listening.